Welcome to AETCM, the emergency medicine channel. Shall I start now? A 40-year-old male patient presented to the ER with complaints of dizziness followed by recurrent syncopal episodes for the past 2 days. On arrival, patient is conscious oriented, airways patent, no pooling of secretions. Breathing respiratory rate is 18 per minute with saturation 98% in room air, chest air entry bilaterally equal. Circulation BP is 120/74 with a heart rate of 70 per minute, and disability is pupil is GCS is 15/15 with pupil bilaterally equal and reactive. Exposure is afebrile. Followed which we
presenting complaint was dizziness and
recurrent syncopal episodes for the past 2 days.
2 days, okay.
And
what is the age of the patient?
40-year-old.
Male or female?
Male. And we proceeded with the adjuncts of primary survey. Initially we took one ECG which shows normal sinus rhythm, and there is a core type ST segment elevation more than 2 mm in V1 V3 followed by inverted T waves. And we took one point of care CBC CRP which shows total count of 6.7, HB of 11 and platelet count of 230,000.
So there was nothing significant in the primary survey.
No.
And we proceeded on to adjuncts which is ECG we took and
CBCRP point of care and VPG we took.
anything other than that that we should take for this patient in as adjunct to primary survey. We took ECG, we took CBC CRP and VPG. Anything else? With the patient who presented with so and so complaint with changes in ECG, what else should we take?
Echo we will do.
Tropi point of care. Then?
And VBG wise there is no metabolic abnormality. Sodium is 132 with the potassium 4.3. And echo tropi is negative. Tropi is negative. Echo, and coming to the ambul history, a 40-year-old male patient presented to the ER with complaints of dizziness while walking followed by abrupt loss of consciousness that is lasting for about 30 seconds to 1 minute, and that is for the past 2 days. Recurrent episodes were the 2-3 episodes for the 2 days. For the total 2 days. And no preceding chest pain, palpitation, sweating, shortness of breath, nausea, vomiting, and there is no history of seizure, tongue bite or incontinence, no history of orthopnea, PND or exertional dyspnea, and there is no history of fever, any recent drug change or drug intake, and no history of electrolyte imbalances. And past history of similar episode was in the 6 months back, and that was evaluated in the outside hospital and treated as vasovagal syncope. And there is no cardiac disease or
so was it evaluated? No.
Basically,
was there any investigation done? No
from the outside
available.
hospital. And no history of previous MA or structural heart disease. And coming to the systemic general examination, patient has no pallor, icterus, cyanosis or coupling, and systemic examination wise CVS S1 has to heard there is no murmurs, and chest wise air entry bilaterally equal, and per abdomen is soft and no organomegaly. CNS no focal neurological deficits. So what we did
did we do an echo? We did an echo.
We did an echo. There is no significant RWMA was not there.
Okay. Nothing else. No.
Good LV function.
Okay. So what do you think the patient has presented to you with? Here you have a 40-year-old male who presented with dizziness and syncope since so and so duration. He also gives a history of similar episodes in the past, and now there is a particular change in ECG which is very characteristic of Brugada syndrome. So what is, as emergency physicians, what is the importance of us identifying a Brugada? What is Brugada syndrome and what is Brugada pattern?
Brugada syndrome means...
what is the patient having?
Now the patient have both clinical criteria.
No, among Brugada syndrome and Brugada pattern, these are the two terminologies. No, what is the patient currently having?
Brugada pattern in
syndrome
criteria, so it is a
Brugada pattern means the patient is asymptomatic but classical features are seen in ECG. In Brugada syndrome, patient is symptomatic with the corresponding changes in ECG. Okay, so what is Brugada syndrome?
Brugada syndrome means it is basically there is a sodium channelopathy. Sodium channel there is
not just sodium, it is a hereditary channelopathy.
which is autosomal dominant because of the loss of function mutation in the sodium channels.
Mainly it is sodium channel, but there are corresponding 8 to 9 mutations which lead to Brugada. That out of that it can affect sodium, potassium and calcium channels. But the main one that is studied is the gene is SCN5A. That gene codes for sodium channels. Okay, so that is basically Brugada, which is hereditary. So in cases which are hereditary, you can get the significant family history also. So you can ask the patient if there was any, among first degree relatives, was there a history of sudden cardiac death or any patient with similar patterns in ECG which was recognized, less than 40-year-old and all, you can ask since it is a hereditary disorder. Okay, so and what do you see? What are the changes in ECG that you see?
There are 3 types of Brugada patterns. The type 1 is curved ST segment elevation more than 2 mm in V1 to V3.
No, more than one of more than one leads in from V1 to V3.
More than one leads in V1, V3 followed by negative T waves. And type 2 is more than 2 mm elevation of saddleback shaped ST elevation. And type 3 is either type 1 or type 2 but it is less than 2 mm of elevation.
In type 2, in type 1 the T wave is properly inverted. So that is why you get a curved ST elevation followed by an inverted T wave. In type 2 what happens is the saddleback is because of the trough. The trough is because of the biphasic T wave. Either here the T wave is not inverted. T wave is either upright or it can be biphasic. And the ST segment elevation should be more than 2 mm and the trough will be more than 1 mm. And so you will get a saddleback pattern, which is more common. Which is in case of since it is a hereditary disorder and a familial history is present, most of the first degree relatives, if you see, if there are first degree relatives available, they'll have type 1 pattern more than type 2. That more suggestive of hereditary pattern. Type 2 is also there but less common than type 1. And in type 3, it can either be of morphology can either be of type 1 or type 2. But the ST elevation will be less than 2 mm. So this is the ECG features. And then in Brugada, what are the risk factors that you should see in Brugada? Like what is the risk stratification in Brugada?
It is personal history is there and family history and also
in personal history what do you
near
look
or
for?
complete syncope, seizure and nocturnal
Why syncope and seizure occurs? Due to cerebral ischemia, this can happen. And there can be nocturnal agonal respirations.
And aborted sudden cardiac death, that's polymorphic VT and ventricular fibrillation. And family history, any unexplained sudden cardiac death. And family history of any curve-shaped ST segment elevation, type 1 ECG pattern. And also EPS study inducibility of the VT, ventricular tachycardia or fibrillation with a programmed stimulation.
So how does a patient with Brugada present to you with? How will normally they present?
Usually with the complaints of dizziness.
May not be. Maybe they'll be purely asymptomatic. Very incidentally you find the changes in ECG. Or else if they are symptomatic, they'll have
dizziness,
syncope, palpitations can be there. What are the, as emergency physicians, why should we identify Brugada in first place? Because it can lead to sudden cardiac death due to what are the arrhythmias that it can induce?
Ventricular tachycardia, fibrillation and AF also.
AF in very rare 20% cases, mainly polymorphic VT and VF. So these patients has to be evaluated, has to be properly sent to the cardiologist for proper evaluation. And there is something in ECG, this ECG pattern can mimic something other than that. Like if a patient has presented to you, I told you, we need to do a tropi for this patient. Why? Because sometimes it can mimic incomplete RBBB type pattern. So a patient who has presented with symptoms and shows such changes in ECG, the RBBB, what do you get? Wide QRS with an M pattern, RS R dash pattern. No, this can incomplete RBBB can mimic this. So we have to rule out ACS as a emergency physician. Our first thing is to rule out ACS. So tropi has to be sent. Once the tropi becomes negative, then you have to evaluate further. So what are the labs that we should do if you suspect such a case, a patient presenting, we think it is likely Brugada. So what are the investigations that we should do? First is ECG. Other than ECG?
Tropi we can send, cardiac enzymes and
CKMB, tropi we can send. Electrolytes, which electrolytes? Mainly?
Sodium, potassium, calcium.
Calcium, because hyperkalemia, hypercalcemia can mimic such changes in ECG. Okay, and other than that, you can advise electrophysiological study, 24-hour Holter, these and everything can be advised from our end. Okay, so these are the things that you can advise the patient. So, and one more, and what are the factors that can precipitate an Brugada? Normal patients who have Brugada with, there are certain conditions where the syndrome get precipitated, which are those? Any kind of minor infection. So you have to do a CBC, CRP to rule out any kind of infection. And what are the drugs that such patients should not take? Which are the sodium channel blockers should not be taken. And what are the drugs? Sodium channel blockers,
flecainide, propafenone, and also calcium channel blockers, alpha agonists, beta blockers, nitrates,
and any antipsychotic drugs like decimipramine, nortriptyline, lithium, and anesthetic drugs like propofol, acetylcholine, cocaine, alcohols. These should be avoided because they can precipitate development of a Brugada syndrome in a patient who has an underlying condition of Brugada pattern is underlying. So as what is the treatment of Brugada?
Cardio.
Only proven treatment is ICD insertion, or you can also do.
We can give quinidine.
Quinidine can be given as an adjunct, but there are side effects also.
Radio frequency ablation.
And like hepatitis, thrombocytopenia can all occur with quinidine. New literature says RFA can also be done. Radio frequency ablation can also be done. So our main focus is to identify patients with Brugada and to distinguish them from, distinguish the characteristic ECG pattern from the incomplete RBBB. And we should advise, what should we advise the patient? First, to treat even a very minor infections, fever, everything has to be treated. So and so drugs which we said earlier should be avoided, and he needs to be evaluated. What is the mortality rate in a patient with Brugada? In 5 years, 50% mortality rate is there. So it has a very high mortality rate. So it is very important for us not to treat Brugada but to pick up Brugada. So that is the main point. So Brugada, mainly patients can present like this also, or patient can present with sudden cardiac death where you follow the ACLS algorithm. So what is the condition where a patient who is a young adult presenting to you with sudden cardiac death? What are the differentials that you should think of?
Maybe due to the ACS, any
acute coronary syndrome, first thing. Okay. That and all comes under ACS, coronary abnormality. Or patient who is having severe LV dysfunction, less than 35% ejection fraction and all can most likely develop sudden cardiac death. Patients with cardiomyopathy, mainly in athletes and all, hypertrophic cardiomyopathy, arrhythmogenic right ventricle dysplasia, and congenital heart issues like severe AS, this anomalous ALCAP, anomalous origin of left coronary from pulmonary artery, hereditary conditions, and channelopathies. This come under hereditary channelopathy. What are the other channelopathies?
Long QT syndrome.
Long QT, short QT. Okay, so these are the things to be kept in mind in particular to Brugada. So importance of Brugada is not just treatment, it is mainly the identification and differentiation from other cardiac pathology.